Welcome to Clinical Minute, Diabetes and Menopause, Risk Reduction. Maisha is a 45-year-old G2P2 who is married with 2 teenage children. She's an executive assistant at an insurance company. She presents today for her annual Well Woman visit. Maisha has a history of type 2 diabetes, diagnosed 5 years ago. She is currently taking metformin, pravastatin, lisinopril, and aspirin. She has a family history of hypertension, type 2 diabetes, and cardiovascular disease. She does not smoke or use recreational drugs. She drinks alcohol occasionally at social events. Maisha says she has been more sedentary since taking her current job 2 years ago and has found it difficult to exercise regularly. She states she has gained back 15 of the 20 pounds she lost when first diagnosed with diabetes. She tells you that her menstrual cycle has become irregular over the last 12 months, with a period about every 45 days. She denies any vasomotor symptoms. She had a tubal ligation after the birth of her second child. She is sexually active. She reports no changes in desire or any vaginal dryness or irritation. On exam, her blood pressure is 130/88, her height is 5 feet 3 inches, and her weight is 175 pounds. Her calculated BMI is 31. You recall that a BMI of more than 30 is considered to be obesity. What labs and other evaluations would you order? Maisha's lab results show a hemoglobin A1C of 7%, mildly elevated triglycerides, mildly elevated LDL, and normal BUN and creatinine. What do you recommend to Maisha for her overall health and reducing diabetes-associated risks? The menopause transition is a time of natural decline in estrogen production by the ovaries and is characterized by menstrual cycle changes and increasingly frequent episodes of amenorrhea. It is defined as being the time period between the onset of menstrual cycle and endocrine changes, specifically variation in the length of the menstrual cycle, to the final menstrual period. Menopause is defined as beginning 1 year after a woman's final menstrual period. Charting of menstrual cycles should be used to determine the onset of menopause rather than hormonal measurement, because ovarian function is erratic during the transition, making these measurements difficult to interpret. The timing of menopause coincides with an increase in prevalence of diabetes. The data in this table show that the absolute number of people with diabetes and the percentage of individuals with diabetes jumps steeply from the first age group, 20 to 44 years, to the second, 45 to 64 years. Does diabetes affect menopause? Research has shown no overall association between diabetes and the age of menopause, with the exception of women with diabetes that is diagnosed before age 20, who tend to have an earlier menopause than women without diabetes. Does menopause affect diabetes? Studies suggest that menopause status per se does not increase the risk of diabetes. However, the metabolic changes and risk factors associated with increasing age are associated with the development of diabetes. For instance, visceral adiposity becomes more common after menopause. Menopause and diabetes share an increased risk of cardiovascular disease. Cardiovascular disease is the #1 cause of death in women worldwide. 2 of the primary risk factors of cardiovascular disease among women, diabetes and hypertension, share common underlying pathways that involve inflammation, oxidative stress, and insulin resistance. The prevalence of type 2 diabetes increases with age for several reasons. An increase in the accumulation of abdominal fat, a decline in the size and the strength of the skeletal muscles, which are important tissues for glucose metabolism, and a reduction of physical activity in older people. These changes in body composition can lead to reduced insulin sensitivity and abnormal glucose metabolism. Menopause causes a similar effect. It is associated with an increase in abdominal fat accumulation related to reduced ovarian function. In addition, menopause is linked to changes in lipid metabolism, with increases in low-density lipoprotein cholesterol, or LDL, evident in the year following menopause. Obesity increases cardiovascular risk and is associated with more severe vasomotor symptoms. The average weight gain at menopause is 5 pounds, which is often due to reduced activity or inactivity. Providers should screen for obesity, calculate the body mass index, and offer interventions based on the BMI. It's important to remember that a weight loss of as little as 5 to 10% of body weight can improve metabolic risk factors, and that physical activity is important for overall health even if the weight does not change. Tips for counseling women with diabetes at menopause include: tailor counseling to women's needs and preferences, provide support for attaining and maintaining healthy weight, counsel all women on healthy diet and activity level, and encourage weight training for boosting metabolic rate and fostering bone strength. For women with diabetes and a BMI greater than 27 kilograms over meters squared, consider pharmacologic options if diet and lifestyle changes are insufficient. For women with diabetes and a BMI greater than 35 kilograms over meters squared, consider bariatric surgery if diet and lifestyle changes are insufficient. Recommend use of statins and aspirin unless contraindicated. Statins are recommended for all women with diabetes aged between 40 and 75 years to reduce CVD risk, regardless of their LDL level, unless contraindicated. Because statins are teratogens, contraception is extra important until it's been confirmed that the woman has had her final period and lost the capacity for pregnancy. Aspirin is recommended for women with diabetes aged between 55 and 75 to reduce CVD risk, regardless of their LDL level, unless contraindicated. The U.S. Preventative Service Task Force does not recommend aspirin to reduce CVD for women under 55 years of age. The recommended dosage of aspirin is 75 to 162 milligrams per day. To help Maisha manage her diabetes and reduce the risks associated with diabetes, you recommend she continue metformin, pravastatin, lisinopril, and aspirin, counsel about risks, including cardiovascular, kidney, and visual complications, as well as neuropathy. You let her know that her diastolic blood pressure meets the criteria for pre-hypertension. You commend her on her overall diet and intake of concentrated sweets, given that her hemoglobin A1C is in the desired range, but recommend reduction in calories to bring her BMI into a healthy range. You let her know that weight reduction can improve insulin sensitivity. A decrease of just 500 to 1,000 kilocalories per day results in 7 to 10% weight reduction over 6 to 12 months. You refer Maisha for an annual eye exam. You ask her to return for monthly blood pressure checks to assess whether additional treatment for hypertension is needed. It is possible that weight reduction will prevent the need for medication. Finally, you ask if Maisha has any questions for you and provide her with a visit summary that lists your recommendations and future visits.